Plenty of bad stuff about the world we've inhabited the last year, but one of the nice things is being able to team up from up north and have a chat with you all, and we're really returning the compliment because Mark's joined our department to chat about processed EEG. This is low-level evidence. This is an anaesthetic colleague of ours describing their experience of residual paralysis in Anesthesia News a few years back. So a young fit person who had an orthopedic procedure, 80 milligrams of rocuronium, 1 hour surgery, and 1 vial of neostigmine. So unlike those high-risk cases we've just heard from Sanjana, so it can happen in the young and fit, struggled to breathe in recovery, felt a desperate air hunger, his airways collapsing, the emergency buzzer was hit, and a vial of neostigmine was given, which eased his ability to breathe, but remained weak with diplopia and discoordinated eye movements for many hours afterwards. And I think this is quite salutary. So residual paralysis, as we've all heard, the definition is a train-to-4 ratio less than 0.9. And approximately roundabout, there's a range, but around about 40% of cases in all the evidence literature over many years would indicate ratios less than that. And it may be surprising to you that there remains an incidence of residual paralysis, the question Emily addressed, even when Sugammadex is used without a monitor. So there's an issue in that what we perceive as anaesthetists and the reality differs, and it's quite fascinating and interesting to delve into this and why this might be. So this survey is one of a few, for example, survey of European and American anesthesiologists, and 2/3 of respondents estimate the incidence of residual paralysis is really very low, under 1%. And the vast majority claim never to have seen a significant case of residual paralysis. So it is fascinating, this discordance, if you like. Here's a meta-analysis published in 2007 with the standard intermediate duration drugs we use. And as you can see, this was 20-odd studies, a few thousand patients. You're looking at around about a 40% incidence of residual paralysis, train-to-4 ratio less than 0.9, and indeed the old money numbers that David Pavan, sorry, not Pavan, but David and myself, and perhaps others of you done the FRCA some time ago, 0.7, even in that situation, around about 10%. And further work published by Naguib shows a wide range in incidence of residual paralysis, obviously less when Sugammadex is used, and I'll come on to that. And here's just one quite interesting and quite alarming study, the RECITE studies. Actually, these were repeated in Canada and China with very, very similar results. So in essence, doing what I do, you do, using neostigmine with or without standard peripheral neuromuscular monitoring, the train-to-4 ratio when measured at extubation and not in recovery, 2/3 of patients haven't achieved 0.9 in that study. This was over 200 patients having abdominal surgery, and indeed 1/3 haven't reached a train-to-4 ratio of 0.6. And the authors concluded that qualitative monitoring and clinical judgment alone are insufficient to detect a failure to return or absence of residual block after neostigmine reversal, and there can be significant consequences. So why is this? I think it's a bit of an iceberg effect because we just don't see it and we don't look for it. So it is indeed very rare to have or know about patients with unexpected coma, death, and indeed awareness under general anesthesia of the order of less than 1%, that tip of the iceberg. It's more common than we think and not always attributed to, as those case examples suggested in your recovery room, up to a few percent of recovery-related hypoxia, desaturation, and the need for reintubation. But there's a much larger number which are, I think, fall into the sort of soup of recovery-related nurse saying, you're not quite right because you've had an anesthetic. This is the diplopia, swallowing difficulty, subtle airway obstruction, reduced hypoxic ventilatory response, and a slower recovery than we might expect. And I think this slide, the differential muscle sensitivity, I think is important just to look at this basic physiology. So if we look over time at the white and the yellow lines on this graph, this is the percentage reduction in single twitch height. So this is onset of paralysis for the larynx, the diaphragm, the upper abdominal muscles. These are the most resistant to paralysis. Quite a quick effect, a limited peak effect, and then a rapid recovery. So it's possible to breathe and be still quite relatively deeply paralyzed. And oh, sorry, my laser pointer has appeared here. Be relatively deeply paralyzed whilst waiting for the adductor pollicis and the more sensitive muscles that we refer to, pharyngeal muscles, the masseter muscles, the genioglossus, and the ocular muscles, to recover. And there are many, many studies which show the consequences of residual paralysis on postoperative pulmonary function and harmful outcomes. This population-based cohort study being one example, over 2,000 patients with a residual paralysis rate in a fifth of those, and significantly higher rates of ICU admissions. Not such impressive detail in terms of hospital length of stay. Sugammadex, just a little bit about Sugammadex. It's an impressive drug when it's used. This gobbling up, encapsulating effect. But the trouble with Sugammadex without a monitor is it's tempting to want to replace the monitor with Sugammadex, but this is one of a few studies, in this case for comparing reversal with Sugammadex and neostigmine, looking at pulmonary complications in older adults having prolonged surgery, and the target to reverse at a train of 4 count of 2. And you can see, firstly, that many patients were reversed deeper than that, which is not a good way to reverse neostigmine, certainly a 50% residual paralysis rate when you reverse from deep. But even with Sugammadex, 10% of patients in this study had a train of 4 ratio less than 0.9, and indeed 3% less than 0.7. So there is, in terms of the primary outcome of the study as well, there wasn't any difference in postoperative pulmonary complications. We still lack the detailed large-scale studies to show that Sugammadex makes a difference. Drug variability. I think Pavan will probably come on to this, but in terms of onset, if you give twice ED95, 0.6 per kilo of rocuronium in this case, numbers of patients, this is work from one of my colleagues, Ali Taylor. If you can look at the pointer when we should be able to intubate at 3 minutes, there's a huge spread with rocuronium, some very quick onset, some very slow onset, and certainly a very variable onset. The only way we know this is to measure what's happening at the start. And as anaesthetists, we have some difficulty with doing this, and we'd like to point out that it's actually very easy when it becomes a part of your routine. And then Emily or Sanjana, I think, referred to duration of drugs. Huge variability and often prolonged duration. This in 500 patients receiving a standard intubating dose with no top-ups. And the percentage of patients in recovery, excuse me, nearly half of those without reversal, without top-up, in other words, spontaneous recovery at 2 hours or more, train of 4 ratios less than 0.9 in a third of patients, and indeed less than 0.7 in just under 10%. So the drugs are very variable and can last a long time. And the only way we know this for individual patients is by measuring them. This study looking at neostigmine effects to see whether neostigmine causes weakness, giving tiny doses, 1 ED95, 25 milligrams of rocuronium, an interesting sub-finding, with an average anesthesia duration more than 2 hours. even then, a fifth of patients don't spontaneously recover train-to-4 ratios to 0.9. So, and certainly if you give syringe fills and you give them based on actual body weight rather than ideal body weight, we can be giving very large doses of these drugs. And finally, in terms of duration, something I think you'll know from your own practice, if you look at duration, this is to recovery 25% of a single twitch height in elderly patients receiving cisatracurium, rocuronium, or vecuronium. The median times are not too dissimilar, but there's a wide range. And so, again, this will be self-evident to you. It's the old, those who get cold, the obese patients, the body cavity surgery, which is often prolonged and needing repeat doses of drugs, top-ups rather, and then other drugs like aminoglycosides and so on that make a difference. And the study that I quoted with a neostigmine reversal for weakness resulted in an editorial and some quite neat infographics from anesthesiology. And Pavan's going to pick up on these in relation to strength tests and fade assessment. So, NAP5, as we know, essentially awareness is awareness under anesthesia with paralysis. And one of many recommendations from NAP5 was that anesthetic organizations should consider including nerve stimulators as essential in monitoring guidelines whenever we paralyze patients. And indeed, in 2015, the previous version of standards of monitoring, the association picked up on this and suggested that we should measure neuromuscular block using a peripheral nerve stimulator, and indeed that this should be mandatory, used throughout all phases, and encouraged 6 years ago departments to move to replace standard twitches with quantitative devices. Of interest, the evidence was clear at the time for quantitative monitoring. The difficulty, as you all know from your own availability of these devices, it's all very well setting standards that are unattainable to our colleagues, and this will be an interesting topic for debate later. So moving on 6 years to the just published standards, and among the key recommendations there, number 6 moves us on to a statement that quantitative monitoring should be used whenever we paralyzed from the start, placed so that we can initiate the nerve stimulator after induction, before paralysis, and until recovery has been confirmed before we wake up, and that recovery is greater than 0.9. And there's reference elsewhere within the minimum standards of monitoring to use quantitative devices throughout all phases. Again, look forward to any chat and debate about the challenge we have just popping the monitors on at the start, and Pavan will show us all how relatively simple that is when it becomes a part of our practice to give us information about onset, effectiveness of the monitor, etc. And then the absolute fundamental key to ensure adequacy of recovery, and it can only be done with a quantitative device. We'll talk a bit more about the range of options, and I know Mark has plans for you to try a number of these: celeromography, electromyography. And so in summary for this first section, residual paralysis is common. There's this disconnection between how common it is and what we think, and indeed whether we think it causes harm, but it does, and it can do. The drugs vary greatly in terms of onset and duration. The clinical signs in the standard nerve stimulator use are inadequate to assess recovery, but there is still benefit from a standard twitcher, as I'd like to point out when I come back to speak to you after Pavan, if that's all you have, as it is all you have at the moment. But ultimately, quantitative monitoring will provide you the certainty which I'm sure will enhance your practice. And as users of BIS, you'll be very aware of this in terms of the hypnotic effects and the nuance you get from that monitoring. So the goal is for us to optimize our airway management and to facilitate surgery and to prevent residual paralysis, and hence the association recommendations as they are. Thank you for listening.